Καλησπέρα σε όλους. Θα ήθελα να καλωσορίσω στο στρογγυλό τραπέζι με τον τίτλο «Παθήσεις ύπατος και παγκρέατος». Και έχουμε 3 ομιλίες σήμερα. Θα δώσω τη σκητάλη στον Τάσο τον Γραμματικόπουλο, ο οποίος βρίσκεται στην Αγγλία αυτή τη στιγμή, να παρουσιάσει την πρώτη ομιλήτρια, η οποία έχει μια ήδη καταγεγραμμένη ομιλία και είναι συνεργάτηδά του. Τάσο.
Ευχαριστώ πολύ, Εύελη. Να ευχαριστήσω ξανά την Οργανωτική Επιτροπή σήμερα για αυτό το συνέδριο που οργάνωσαν για τρίτη φορά πανελλαδικά. Θα παρουσιάσω τώρα, θα κάνω την εισαγωγή για την Miss G Geaney, που είναι μια εξειδικευμένη παιδοδιατροφολόγος στο κέντρο ύπατος και παγκρέατος του King's, και είμαι στην ευχάριστη θέση να πω ότι πλέον στο Ηνωμένο Βασίλειο έχουμε ξεκινήσει ένα συγκεκριμένο group από ειδικούς που ασχολούνται με παθήσεις του παγκρέατος και μόνο, κάτι το οποίο προσβλέπουμε στο μέλλον να έχει πολύ μεγάλη εξέλιξη, και η Gillian είναι η διαιτολόγος που συμμετέχει σε αυτό. Η δικιά της ομιλία έχει να κάνει με τη διατροφική αντιμετώπιση ασθενών του παγκρέατος στα παιδιά. Gillian, just did the introduction, so your talk will be starting in a minute. Ευχαριστώ πολύ.
Good afternoon. My name is G Geaney, and I am a specialist pediatric dietitian working in the areas of hepatology and pancreatitis at King's College Hospital in London. I'm here today to present to you about the nutritional management of pediatric pancreatitis. So here's an overview of the presentation. We'll go through first some of the guidelines that are now available for this topic, and then look at each individual heading. So initiating nutrition enterally, the ideal route of feeding and the evidence for this, the feed composition that we know to be best for enteral nutrition in acute pancreatitis, the use of parenteral nutrition and how this compares against enteral nutrition, the use of a low-fat diet, so explaining what is a low-fat diet, how it is used and for how long it might be beneficial for, and then a brief note on pancreatic exocrine insufficiency, anthropometrics and other considerations to consider, which hopefully we will have a small amount of time to discuss also. I have no conflicts of interests to declare. So up until about 2018, we had very little in the way of guidance. In 2018, we actually got a flurry of clinical practice guidelines and position statements from various bodies. So today I will use the joint ESPGHAN and NASPGHAN position paper from 2018, along with the European Pancreatitis Committee and the Hungarian Pancreatic Study Group documents to guide a lot of the recommendations that we have in practice. There's also the NASPGHAN clinical report for acute pancreatitis, and very, very recently, as you will see, we need to use a lot of the adult literature still, because there isn't a lot of research for pediatric pancreatitis yet. And so we're looking at the ESPEN, the European Society of Pediatric Parenteral and Enteral Nutrition, to guide some of our practice. What has been nice in 2019 was the publication of this paper by a Greek group looking at the comparison of all of these guidelines and how they compare against each other and what they look at. So you can see we have the joint ESPGHAN and NASPGHAN position paper covering a lot of interesting topics around nutritional management, also the EPC and the NASPGHAN clinical report. You can see here the BC, the Belgian consensus statement, looks mainly at chronic pancreatitis and therefore will not include it today. So let's jump in. The first topic, the initiation of enteral nutrition. So when to start enteral nutrition. By enteral nutrition today, I mean anything fed via the GIT, be that oral or via a tube. We have a lot of adult data that we can look towards to guide our practice. A meta-analysis of about 17 randomized controlled trials showed that 84% of these patients with mild and moderate acute pancreatitis tolerated oral diet well. There was a reduced overall mortality even in those with severe acute pancreatitis when fed early. And there was actually an increased risk of bacterial translocation and a longer length of stay if enteral feeding was delayed beyond 48 hours. In children, we don't have quite so much research to rely upon. We have an observational study, retrospective designs, mainly Ellery et al. 2017, looking at the safety of initiating enteral nutrition within 24 hours, was deemed to be safe and with less disease progression. Also, Abu El-Hajja et al. 2016 found that there was a similar pain score between those who were kept nil by mouth, those who had a clear fluid diet, a low-fat or normal fat diet, and actually those who were fed enterally had a shorter length of stay. There was only 33 patients in this study, so as you can see, these differences didn't reach a statistical significance. Initiating enteral nutrition was historically something that we didn't do very quickly. We gave the pancreas and the gut some rest, but actually we now know that enteral nutrition early is favorable, and therefore if children are not motivated to eat orally within the first 72 hours of admission, we should be considering the placement of a feeding tube. So this slide summarizes the recommendations for this heading. Children with mild acute pancreatitis should be started on a regular diet and advanced as tolerated. Enteral nutrition should be attempted in children even with severe acute pancreatitis within 72 hours. And the EPC states similarly, if oral diet is not tolerated or cannot be achieved within 72 hours, an enteral feeding tube is recommended. Interestingly, the EPC also states oral feeding can be started even in the presence of systemic inflammation and before serum amylase and lipase levels normalize. And this is the same as quoted in the ESPEN adult guideline documents. It should be symptom-led rather than led by the biochemistry. So how do we feed? If we do put in a feeding tube, is there evidence to say that gastric or jejunal feeding is better? Unfortunately, there is no evidence for pediatrics specifically, and so again, we're looking to the adult data. Here, the ESPEN documentation for 2020 does state that gastric feeding has been found to be safe and effective in both mild, moderate, and severe acute pancreatitis in adults, and there are many, many studies involved in this. The clinical course and the complication rates have been similar. The indications for nasojejunal feeding are there, and they are usually for if their patient is experiencing ongoing symptoms of delayed gastric emptying, symptoms of pain upon gastric feeding, and symptoms of vomiting that may persist. If a child presents initially with quite severe nausea and vomiting, it may be prudent to go straight to nasojejunal feeding, and this can help with those symptoms, and it can be useful to put in a tube during ERCP so that the position can be confirmed in a timely manner. So here are the recommendations. Oral or NG feeding in children with severe acute pancreatitis is likely to be safe and beneficial. NJ feeding is indicated when oral and NG are not tolerated. And the agreement within the consensus panels is high for these recommendations. So grade 1, 100% of panelists agreed. So then what do we put down the tube if we are feeding? This again is another area where there is a lack of data for pediatrics. So we're looking at adults. In adults, there have been 2 separate meta-analyses of randomized controlled trials, and neither found any difference or benefit of a semi-elemental formula compared to a whole protein. In pediatrics, our first line is a whole protein polymeric feed as first line. Then we look at immune nutrition. Immune nutrition is a relatively new concept. It broadly reflects any components that can be added to an enteral feed to reduce inflammation, improve overall disease outcome. Amino acids such as arginine, glutamine, or things like probiotics or even omega-3s can be added into a feed. However, there is no evidence to prove benefit in pediatrics, and they are deemed unnecessary. In respect to probiotics specifically, there has been a meta-analysis of 6 randomized controlled trials as completed in the adult groups, and they have found no proven benefit of probiotics in acute pancreatitis and potentially some harm. Therefore, they are not recommended. To summarize, the use of a specialized formula or immunonutrition is not necessary for pediatrics, and probiotics cannot be recommended. However, this does not have a grading. Next to parenteral nutrition. So historically, again, parenteral nutrition was looked to very quickly for pancreatitis patients. And this again was the theory that giving the pancreas and giving the gut rest would be a good thing. However, there has been a massive shift in the paradigm and the way of thinking about this, and we now know enteral nutrition to be more favourable. Sadly, again, there have been no studies comparing enteral and parenteral nutrition in children. And so again, we look to the adult data. In 2010, there was a meta-analysis of 8 randomized controlled trials, including 348 patients. Here it was found that there was a 50% reduction in overall risk of mortality when a patient was fed enterally compared to receiving exclusive parenteral nutrition. This increased to a reduction of up to 80% in those with severe acute pancreatitis. There was also benefits which reached statistical significance for reduced infection rates and reduced risk of multi-organ failure. This was replicated in a more recent meta-analysis, including 11 randomized controlled trials, where again, the reduced risk of overall mortality was replicated. Here on this figure, you can just see briefly the comparison of risk reduction for infection and for complications in those fed enterally versus parenterally. So the recommendations for PN. PN should be used only when enteral nutrition, either oral, gastric or jejunal, is not tolerated. And where you are using PN, a combination of enteral and parenteral will be better than giving PN alone. And this again is to give the gut some nutrition to reduce the risk of bacterial translocation, subsequent infection and longer length of stay. There are going to be times when you do need to give a patient parenteral nutrition, instances of prolonged ileus, predicted prolonged ileus, fistulating disease or necrotizing pancreatitis. And in these cases, we should be constantly thinking when it would be safe to reintroduce some trophic enteral feeds. Low fat, what is the evidence? So this is a very topical area within pancreatitis. Low fat is something that historically, again, has been recommended very, very freely. With the theory that you're reducing the stimulation of the exocrine pancreas, reducing the secretion of amylase, protease, and lipase enzymes in response to food. The evidence, again, is very, very scarce for pediatrics, and we have one study where Abu El-Haja and her group in 2016, the same 33 patients we mentioned in relation to the early initiation of feeding, looked at the impact of fat intake measured in grams per kilo per day, on lipase levels and on pain scores measured daily. It was found here in these 33 patients across 38 hospital admissions or episodes that the pain severity was actually lower when higher fat intakes occurred. Similarly, lipase levels decreased as dietary fat increased above 1 gram per kilo per day. Now, this reached statistical significance in this group, but it is not something that we can easily take and apply to our own practice. And this is because the fat was increased over time. Therefore, as fat was increased, you might argue that lipase levels were already on a downward trend, or the pain would already have been improving. What we would love to see is, can we give fat safely at the early stages of enteral feeding rather than down the line? There has been no study in pediatrics that has looked at the prolonged use of a low-fat diet. In adults, low-fat diet is more so in relation to symptom relief for symptoms such as dyspepsia and delayed gastric emptying. And I guess we should think here that the causes of acute pancreatitis in adults are very, very different to those in children. These symptoms are very common in adults, and actually treatment with a low-fat diet has the benefit of weight reduction and better management of triglyceridemia. So we do know that the use of a low-fat diet has a different end goal in adults compared to children. In children, we may want to reduce total calories, we may want to get their weight down, but in many cases we don't. And we're only using a low-fat diet if there is symptomatic benefit. In chronic pancreatitis, in adults, it is only recommended if there is symptomatic benefit. Now, this might be, again, dyspepsia or pain, or it might be that if compliance to enzyme therapy is poor, a patient adapts their diet to reduce symptoms of steatorrhea. So in terms of recommendations, is grade 1C evidence from the Espegan-Naspegan joint position paper to state that a regular fat diet can be started within 1 week of an episode of acute pancreatitis, unless caused by hypertriglyceridemia, in which case a long-term fat restriction is advised. When tolerated, children should have a regular diet between episodes of acute pancreatitis. However, we know that in practice this isn't always the case. And if a child has symptomatic benefit, reduced pain with a low-fat diet, then this should be continued and increased as tolerated as soon as possible. This is where ongoing monitoring post-discharge can be really, really important. So what is a low-fat diet? A normal fat diet, if we start here, is usually about 40% of energy coming from fat for 1 to 3-year-old children. As somebody gets older, that reduces to about 25 to 35% of total energy coming from fat. This includes all types of fat, long chain, medium chain, saturated, unsaturated. It will have the same sources in the diet and impact. There is no recognized definition for what constitutes a low-fat diet. There has been no consistent and reliable definition, and this has resulted in a massive variety in what happens in the management of these patients. As there has been kind of no strict definition, what I tend to do in practice, and where is a very reasonable place to start, is reducing by at least 50%. So that will be reducing the fat content of the diet to be less than 10% of energy from fat. And when you're practically advising a family how to adhere to this, when they're shopping or reading a food label, it would be choosing foods with 10 grams of fat per 100 grams of food or less. In the UK, we have labels which are like a traffic light system. So you can easily see, in this case, you're just looking for less than 10 grams per 100 grams. If there is no symptomatic benefit in this, then you can go to an ultra-low fat diet, which the food industry defines as less than 3 grams of fat per 100 grams of food. Now, these are not advisable to continue for a long period of time, because any diet which has this little volume of fat will have a lack of fat-soluble vitamins and essential fatty acids. Therefore, if a child symptomatically requires a very low diet, they should be trialed on at least the 10% fat diet over time and see if they can progress back to normal as the disease resolves. It is important to mention here as well that when you cut fat down in the diet, you're cutting a lot of calories. Each gram of fat contains 9 calories per gram compared to 4 calories per gram of protein and carbohydrates. Therefore, you're really, really reducing the total energy intake. And if a child has recently lost weight or needs extra calories for catch-up growth, it can be very difficult to achieve. If you can't supplementing with proteins, carbohydrates, then you may need to prescribe some fat-free oral nutrition supplements, which are available for children over 3 years of age. And replacement therapy. As per the Espegan guide, acute or acute recurrent pancreatitis without demonstrated pancreatic exocrine insufficiency. However, there has been the use of some enzymes empirically if patients struggle with pain, despite being pancreatic sufficient. So if patients are experiencing some abdominal cramping, flatulence, or even steatoreacting, you can use empirically to see if this helps. And that is, the theory is that it's reducing the endogenous secretion of enzymes by ensuring that there is an exogenous supply. The dosing of lipase is difficult because there is so little evidence for pancreatitis with cystic fibrosis guidance, and the starting dose advised is about 4,000 units of lipase per kilo. Now, this would be mainly for pancreatitis, but as I say, sometimes, although without evidence, it is used for pain management. For younger children, we dose per feed or per breastfeed. For older children, we dose per meal and snack per kilo. So you start with here 1,000 units of lipase per kilo per meal, increasing to 2.5. For older children and adults, we dose per meal. The advice is to increase the lipase rather than to reduce the fat when it comes to children. diet. And there is generally a kind of an upper limit suggested of about 10,000 units of lipase per kilo per day. Other considerations, just to mention briefly, are nutritional requirements. Again, this is an area with no for the pediatric population, but depending on the severity of disease, you may need to increase energy and protein provisions by 10 to 20% to account for recent weight loss or to maintain growth. We know there's a lot of catabolism in acute pancreatitis. In terms of growth, we're aiming to maintain premorbid centiles and normal height and weight development going forward. We need to consider the role of psychology. In some cases, we have patients who develop fear of eating, especially if they've had symptoms of very severe pain with a high-fat diet. And therefore, psychology can help really work through this with patients alongside dietetic support. Also, if you need to have patients complying longer term to a low-fat diet or to enzyme therapy, and psychology can be really helpful to get them through this. Lastly is monitoring for chronic pancreatitis. We know that the risk of malnutrition is a lot higher in the chronic pancreatitis group. And we know that pancreatic exocrine insufficiency is present in 1/3 of this group. So it is really important to keep monitoring fecal elastase and also signs of endocrine dysfunction via HbA1c to ensure that we're on top of pancreatitis, which can really affect nutrition. Also monitoring fat-soluble vitamin levels and bone health in the longer term. So in conclusion, we know that more research is needed in the area of pediatric acute pancreatitis. We know that early nutrition is favourable, and we know that gastric or oral feeding is well tolerated in most patients. If it is not well tolerated, nasojejunal feeding is safe and effective. Parenteral nutrition should be reserved because of demonstrated enteral feed intolerance, and where possible, a small enteral or trophic feeding should be maintained alongside the PN. There is no ideal feed composition that has been proven in pediatrics, but currently our first line is a polymeric whole protein feed. And finally, there is limited evidence for the benefit of low-fat diet in acute pancreatitis, and the aim to resume normal fat content as soon as possible and between episodes of acute recurrent pancreatitis. Having said that, if there is a symptomatic benefit of reducing fat, this can be continued and fat reinstated as soon as tolerated in the community. Thank you. Any questions?
Thank you, Gillian. That was really interesting. Thank you. I think you addressed the issue on the basis of the evidence we've got. Για το κοινό, να πω και τους ακροατές ότι φυσικά, δυστυχώς, στην παιδιατρική αυτό που τείνουμε να κάνουμε στην παγκρατίτιδα είναι ότι μυρικάζουμε λίγο τα στοιχεία που έχουμε από τους ενήλικες. Δεν υπάρχει, δυστυχώς, βλέπετε το επίπεδο από το evidence είναι πολύ χαμηλό στις παιδιατρικές μελέτες και αυτό είναι ακριβώς κάτι το οποίο θέλουμε να αντιμετωπίσουμε με το καινούργιο group παγκρατίτιδας που θα κάνουμε στο Ηνωμένο Βασίλειο, στο οποίο προεδρεύω. Να δούμε, δεν έχουμε κανένα λόγο να πιστεύουμε ότι τα παιδιά θα είναι διαφορετικά από τους ανήλικες. Αν μη τι άλλο, έχουν πολύ πιο ήπια μορφής παγκρατίτιδες σε σχέση, μιλώντας στο γενικότερο πληθυσμό. Αυτό που χρειάζεται όμως είναι να δούμε ότι πραγματικά με την πρώιμη σύντηση αυτών των παιδιών, ότι ίσως να μπορέσουμε να τους κάνουμε να βγουν από το νοσοκομείο πολύ πιο νωρίς, να είναι λιγότερο τραυματική αυτή η εμπειρία και να μην υπάρχει αυτό το πολύ έντονο ψυχολογικό κομμάτι το οποίο φαίνεται να επιβαρύνει τους ασθενείς με παγκρατίτιδα, ίσως όχι τόσο αυτούς με την οξεία, αλλά πολύ περισσότερο με τη χρόνια. Έγλη, θα ήθελες να κάνεις κάποιο σχόλιο?
Ναι, νομίζω ότι πέρασε πάρα πολύ ωραία μηνύματα, τα οποία θα πρέπει όλοι να έχουμε υπόψη μας. Δηλαδή, στην οξεία παγκρατίτιδα σιτίζουμε νωρίς, χρησιμοποιούμε κανονικό γάλα εντερικά, δεν κάνουμε παρατεταμένη δίαιτα, άλυπη δίαιτα. Και δυστυχώς πολλές από τις οδηγίες που βλέπουμε όταν φεύγουν οι ασθενείς μας από το νοσοκομείο γράφουν άλυπος δίαιτα για 1 μήνα. Και εδώ πρέπει να προσέξουμε, όπως τόνισε, για την έλλειψη των βασικών λιπαρών οξέων. Πολύ ωραίο που είπε ότι μπορούμε να χρησιμοποιούμε έστω και 10% lipid containing diet. Αυτό είναι πάρα πολύ σημαντικό και διευκολύνει πάρα πολύ και την τήρηση της δίαιτας και το ψυχολογικό των παιδιών. Και ήθελα να τη ρωτήσω μία ερώτηση, αν μπορούσα. Mrs. Geaney, I wanted to ask you a question. At King's College, which formula would you use first line? You said you're not going to use elemental formula, but you're going to use a polymeric. Do you use MCT containing or not?
Typically not. Typically we'll just do a standard 1 calorie per mil whole protein formula that would have very little MCT. If there's a suspicion of malabsorption due to allergy or due to some other reason, then we would use a peptisorb feed. And peptide feeds tend to have a higher MCT content just because of this. So oftentimes a peptide feed might have 30 to 50% MCT. Only use MCT as a first line if there is suspected malabsorption.
Okay, thank you. That was very good.
And if they are cholestatic as well at the same time, if there's a biliary problem?
If it's an obstructive jaundice picture, CTs would be beneficial for that reason, but it depends, I guess, how quickly the treatment for the jaundice is carried out. And if we're feeding thereafter, that the jaundice has cleared and it's not something that's going to persist, then we wouldn't use MCT.
Thank you very much. Thank you, Gillian.